Now we get on to today's presenter, and we're delighted to welcome Dr. Austin O'Carroll, who's a member of the Irish College of General Practitioners, Professional Directorate in the Health Practice. He's also a Fellow of the Royal College of Physicians of Ireland. Dr. O'Carroll is an inner city GP and has been there since 1997. The focus of his career has been improving access for communities affected by marginalisation and deprivation to quality primary healthcare, and he's also founded several initiatives. He's the founder of SafetyNet and North Dublin City GP Training Scheme, and he's the co-founder then of GNQ, Currum Healthcare, and PHE Partnership in Healthcare Equity.
Okay, that's the go-ahead, Lorraine, is it?
Yes, that's the go-ahead.
That's the go-ahead. Thank you very much. Thanks very much, and very nice to meet everybody. I'm just going to share my slides now with you, just to check. That's great. Can everybody see that okay? Is that okay?
Perfect.
So, nice to meet you, everybody. I'm here to talk to you about trauma-informed care. And I'm not a particular expert in it, but I just work with the issue of trauma, as in fact, I can absolutely guarantee all of you do too as well. I have to give credit. The person who introduced me to this vein of thinking was Sharon Lambert from Cork, who, if you ever get a chance to listen to, she's a much better speaker than I am. She's fantastic. I'm going to start off with just a story about a young woman and man that used to be patients of mine. And around 10 years ago, they were both, by the way, I just let you know, I'm in the clinic that I normally work in, the Granby Clinic. So I'm in my surgery in the waiting rooms outside. So they used to attend me in the Granby. But the way they got involved with me was they had been rough sleeping for around 5 years in Stephen's Green, where they had a tent and they were addicted to heroin and crack cocaine and alcohol. And they basically, one Sunday, it was lashing rain and freezing cold, and their tent was blown down. And because all services were closed, they were wandering around with nowhere to go. And eventually he developed hypothermia. And they went into the one of the local inner city hospitals, and he lost consciousness. And as the doctor was cutting off his clothes to try and get treatment for him, himself and the nurse turned to herself and said, "This is disgusting, the condition you've got yourselves into." And this is a view of addiction and of homelessness, that people who would do these are somehow personally responsible for becoming homeless, for becoming drug addiction. And this is probably the pervasive myth about addiction in particular. Irish people tend to be very sympathetic towards people experiencing homelessness. And you'll often see newspaper reports about people giving out about the homeless situation and how can people be homeless. And I remember there was a lot of protests about people when homeless people die. They tend not to be sympathetic towards drug users. For example, one of the major charities that works with people who uses drugs raises millions of money every year. But in all its campaigns, it never mentions about drug use. It mentions about homelessness because it knows it won't get people contributing. And you never see people campaigning about people who die in the streets from drug use, even though the people who die from homelessness are usually people who use drugs. So this is the attitude that fed that doctor when those patients came in. And the result was that when he recovered, the two of them went out and they swore, "We are never going into hospital unless we're dying again." And the sad thing is that that doctor, I believe that doctor lost out, because I don't blame the doctor. If you're not going to blame people, you can't blame, you have to hold, you just can't blame. And my belief is that, you know, this is stigma that's pervasive in society, and that stigma gets boiled down in an environment where people are overworked and stressed out, and such as in a hospital. So the stigma gets absolutely concentrated, and that's what happens. And but that doctor and nurse, they didn't enter medicine to do that. They didn't enter medicine to cause two people to say, "I'm not going to go for treatment." Everyone enters medicine and nursing to try and help people. You want to change people's lives. And they lost that opportunity because those two same patients went into a mobile health unit that we have, which was staffed by a young GP trainee. And that GP trainee engaged with them in a much more open and empathic manner and asked them, they came in for a chest infection, she treated it. Then she asked them what was their situation. situation and about their drug use, and she persuaded them that it would be worthwhile getting their drug and alcohol treatment. They went to Merchants Quay, where they met amazing Lena Kelly, who referred them up to us. We got them onto opiate substitution treatment. Dublin Simon got them off alcohol. Dublin Simon got accommodation. And Dublin Simon got them to do their leaving certs, and they both did their leaving certs. And then they got the Trinity Access Programme, and they ended up entering Trinity. They got actual entry into Trinity College through the Access Programme. And this is where the stories diverge. Because just around 2 months before they were going in, they were both very confident, really happy. But 2 months before they were about to go in, he suddenly lost it. And you can come up with whatever psychiatric diagnosis you want. He had an old-fashioned nervous breakdown. That's what I believe. He would just literally lost his nerve. And when he saw that he was going into college, something he'd never expected, something that was alien to him, I think he just lost it. And he had a nervous breakdown, crashed, and suddenly decided he wasn't going to go to college. And we had him on various treatments. We were there trying to persuade him, but he wouldn't go. She went and he didn't. And they were living together. And after a while in college, she moved out on her own, but she visited him every single day. We kept on working with him to try and persuade, but we just could never get his back to the same level of enthusiasm and happiness he'd been previously. And we could never persuade him to go back to college. And very sadly, after 2 years, he committed suicide. She actually went on, completed psychology, then subsequently did a master's in psychology, and she's actually out in my waiting room because she works for me as a psychologist here in the thing. Now, I know it was a sad ending for himself, but it was still the right thing to do, to offer that opportunity. And that's what that doctor lost, an opportunity to change people's lives. But how does this relate to trauma? It relates to trauma in 2 ways. I believe if you actually go into this guy's background, he had an incredibly traumatic background as a child. And I think that trauma had affected his sense of worth, his sense of self-esteem. And when he saw something coming to him that was not for him, was not a world that he ever thought he would be in, that he felt out of, he totally lost the confidence. And then he saw his one support he felt was going away. She wasn't to every day. And basically, he hadn't got the inner capacity because he hadn't, due to the trauma he experienced as childhood, he hadn't developed the resilience to be able to manage that, and he couldn't face it. It's also a story of trauma because if you adopt a trauma-informed lens, and when you see 2 people coming in like that, you don't think this is a condition you've got yourselves into. You think this is what our society has done by creating the situations that cause trauma. And this is what the effect of trauma is. And when you see it through a trauma-informed lens, it causes you to be much more empathic and much more ability to engage. Behavior has meaning. If there's one message I'm going to get across to you, is behavior has meaning. As one commentator said, it makes a great deal more sense of much of the seemingly unreasonable behavior or outrageous behavior of many adults if one bears in mind that they are often doing to others what they experience has been done to them both externally and internally. So in this waiting room that's outside, this is a year or 2 ago, we had 2 clients who were coming in. We do benzodiazepine detoxes, and they were both coming in for a benzodiazepine detox. They were partners, and they had their child with them. And we have 120 people visit this place. We have 4 doctors, and we have 120 and a nurse, and 120 people every morning. So it's a lively waiting room. Anyway, they were in the waiting room, and the child was playing with something in the corner. And the father turned to the child and said, "Stop doing that." And another man who's in the waiting room said, "Leave him alone, he's fine." That's all he said. "Leave him alone, he's fine." And instantly, I happened to be just coming out and I saw this guy just jump up. I saw his face bulge, and he went straight for the other guy who said, "Leave him alone." Luckily, Tommy, who's my manager, was there, and Tommy managed to grab him before he got to the other guy. Tommy had to get a second guy. Your man was you could see his veins bulging. They managed to get him outside the room, bring him outside the door. When he got outside the door, they closed the door. He smashed the windows on the door. He assaulted someone on the pavement, and he went across the road and then assaulted someone else, and the Gardaí came along and then picked him and took him off. I'm really proud. Now, this doesn't happen often because I want to be sure it just sounds like my waiting room. This doesn't happen extremely rarely. I've only a few times seen someone. I've actually, he's the worst I've ever seen in terms of reaction in the waiting room. But I was really proud of my staff because when the clinic was finished the next day, they came in to me and said, Austin, we think we can work with that guy. And I was delighted because his partner had come in, they had a child, and the partner was doing the benzo detox. He now wasn't doing a benzo detox. Her chances of succeeding in doing a benzo detox were really diminished because her partner wasn't doing it. The child was going to lose out. By the way, we had to report to Tussle and all that, but the child was losing out. But so I was really proud that they said, we'll treat him. And we brought him back in, and we brought him back in at the end of the clinic, and we talked to him. And eventually, anyway, he thanks very much. I hear that, Commissioner Stewart, and I appreciate it because language is important. Thanks for that, Fiona. So the where was I? Oh yeah. So anyway, we brought him back in at the end of the clinic, and we actually treated him for the benzo detox. And in fact, by the end of the benzo detox, we were able to bring him into the normal clinic. Now, when I saw him jump like that, I actually just saw a young child in an adult body having a temper tantrum. And when I did discover his background, it went with my instinct. He's a person who, when he was a child, rules were enforced with stick and fist and shouting. And the way he learned to protect himself as a child was to shout and fight back. And that was his reaction, just instant. It was like it's an instinctive reaction. It's like, someone who's learned to survive, but through instinct. You instinctively become aggressive. So um, that to me is the behavior has meaning. Once you see the behavior through a trauma-informed lens, you stop seeing it as violence and a bad person. You see it as this is the way the person has learned to defend. Now, obviously, they have to learn to behave differently, but by working, we were able to work with him and obviously explain to him you can't behave that way. But we're also able to help him understand that his behavior comes from his own trauma as a background. So I'm starting to move to the next slide. So I'm going to talk now about the science of trauma. And interestingly, the science of trauma is that this was all discovered. The concept of trauma really arose from a particular study run by an American insurance company called Kaiser and Permanente. And basically, they were doing some research into, I actually can't remember what it was, but as part of the research, they wanted to make sure that their findings would not be affected by if the person had a lot of trauma as a child. In other words, it wouldn't be a confounding factor. So they assessed to find out about trauma experiences. And as they did this, they suddenly found that the real story was not what they were originally researching, but the real story was in the adverse childhood events. And basically, childhood experiences are powerful determinants of who become as adults. There's a lot of talk about stress. And I often hear, particularly young people, talking about stress and how they're overstressed. And I sometimes get anxious about this because I think sometimes we are failing to realize that stress is a normal part of life. And in fact, not only is it a normal part of life, it's a particularly important and positive part of life. So positive stress is where you get a response to being under, being under a stressful situation. And you have to be able to manage it, because that's part of when you're growing up, you have to learn to manage stressful situations. When you're with your friends and there's issues going on, you have to learn how to manage them. That's positive stress. When you're working and you have to work to a timetable, that's positive stress. Every single day we deal with positive stress, and you have to learn to cope with positive stress because it's part of life. If you can't cope with it, then you have a difficulty coping with life. So there's positive stress. Then there's what we call tolerable stress. Tolerable stress is where the stress is more severe. And if you apply this to children, a lot of times they actually, say, for example, if they experience bullying in school, or if they experience that their friend is suddenly not talking to them. The thing about tolerable stress is that what generally makes it tolerable is that you actually it's is support from someone. So the fact that you've got support, and as a child, obviously that's your parents generally. It can be other adults, it can be a supportive teacher, it can be supportive friends, but generally it's an adult. And I don't know if any of you had issues with children who were bullied. I had both my children were bullied. I also, by the way, both my children at one stage I had to talk to about bullying. I always had an issue that parents think their own children are always bullied, but never bullies. And children end up doing things. But anyway, when they were being bullied, it's really difficult. I don't know if anyone's experienced it, but sometimes I had to talk to parents on one occasion. Some of the parents agreed, some of the parents didn't accept it. And eventually I learned that the best way was, rather than trying to address it with the parents, was to try and teach my child on how to manage it. So I tried to give her the skills to be able to name the bullying, to be able to name it, you're bullying me, to be able to address it, to be able to make other friends, to know which friends to let go. And same with my son, I had to do the same. So that was the support we're able to give. It isn't just about support in terms of belief in them, that, listen, I know they're picking on you, but we believe in you. But it's also support and giving you the skills to manage that. So that's tolerable stress. Toxic stress is where you have strong and prolonged activation of stress responses systems in the answer of buffering protection. I have to explain that this isn't just a psychological thing. It's an actual, well, it is psychological, but it is actually physiological processes happening in the brain. We have stress hormones, which are adrenaline and cortisol. They're released. They're released in small amounts when you've got positive stress. They're relieved in larger amounts, but they're managed when they're in tolerable stress. But when you get toxic stress, you have strong, prolonged release of these cortisol and adrenaline. We know, for example, strong, prolonged release of stress hormones causes you to have reduced life expectancy. They have huge impact on your health and welfare, your physical health and your mental health. And these are people where you've got children who've recurrent abuse, neglect, severe maternal depression, substance abuse, family violence, and they don't have those strong people, parents, because the very people who are there would normally there to support you are often the people, the perpetrators of the violence. And this means the prolonged stress hormones, you increase susceptibility to cardiovascular disease, hypertension, obesity, diabetes, mental health problems, amongst other things. So this gives you a visual image of the different types of stress that you can see. So you've got there's positive stress, which is solved quickly. Then you've got tolerable stress, where you actually have people who supports, and then you have people who have toxic stress, where they can't cope and the stress goes on and on. There's also certain people who are resilient. Often people who've experienced severe stress. For example, originally resilience, the concept came particularly for migrants, and that basically they learn how to dissociate from the stressful situation. It creates its own issues, but it also is a very protective thing. So that's the issues about stress. So let's go back to trauma. Trauma is much more than a story about the past that explains why people are frightened, angry, and out of control. Trauma is re-experienced in the present, not as a story, but as profoundly disturbing physical sensations and emotions that may not be consciously associated with memories of past trauma. Terror and rage and helplessness are manifested as bodily reactions like a pounding heart, nausea, gut-wrenching sensations, and characteristic movements that signify collapse, rigidity, or rage. So around 7, 8, 9 months ago, I had this young girl come in with a key worker, and she was around 18. And she was coming in for a particular treatment that we were offering her, but she needed to come regularly for this treatment. When she was here, the key worker explained that she had tried to go to other doctors, but had tended not to go back. She tended to avoid going back to them. And so I was there and I was very friendly with her. But then I decided I sometimes use a technique, particularly with young people, is sometimes to sound like to take the fatherly approach. And sometimes the fatherly approach can be, I'm really fatherly and caring, but sometimes the fatherly approach is slightly giving out, but in a caring way. So I said, listen, we're delighted to help you. We're going to help you. I says, but it's really important that you turn up every week. I really need to insist that you turn up every week so that we can do this. Does that make sense? I really need you to do this. It's really important. So she jumped up and told me to fuck off and take whatever medications I had, and she wasn't going to come, and stuffed them up my arse. That's what she said. And she started to rage at me and was going for the door. Now, luckily, I have learned a technique in medicine behavioral technique, which is called the fulsome apology. I just went straight into apology mode. I said, I'm so sorry. I'm really sorry. I apologize. I got it wrong. I am so, so, so sorry. She managed to calm down. I managed to listen. I said, I apologize. I was lecturing you rather than listening to you, and I am really sorry. So we sat and we managed to agree that we'd give her treatment, and she agreed to come back. And she has managed to complete her treatment, which is fantastic. Now, trauma-informed care approached, someone once said to me, he says, Austin, that was very, that was very good that you weren't able to take it personally. And I said, that's what trauma informed. So that wasn't about me being personal. That was me just learning about trauma. When you understand something is trauma, this is a girl who was experiencing a past event in the present where she was getting terror, rage, and helplessness as body reactions with pounding heart, gut-wrenching sensations, and was developing rage. She had gone straight back into the past. She had an incredibly traumatic background. And I, of course, had stimulated that by talking as a parental type figure, which was obviously a trigger for her. But knowing that from a trauma-informed thing allowed me see immediately what has happened, and that enabled me to go into the apology mode. So trauma-informed allows you understand what's happening in the present and helps you see the behavior for what it is, rather than taking offense, taking anger. It avoids you getting afraid, it avoids you getting angry at the person, it allows you to manage the situation much more effectively. I go down to the adverse childhood experiences and the evidence of what the impact of trauma is on people's lives. So, as I said, when they did this original study, they identified 10 adverse childhood events. These are experiences of abuse, neglect, and family dysfunction. And I'll go on to their impact in a while. But first of all, I'm going to just explain what in the original study they identified was physical abuse, emotional abuse as a child, or sexual abuse as a child, physical and emotional neglect as a child, and then if there was parental mental illness, parental imprisonment or incarceration, a parental domestic violence, parental substance misuse, or parental separation or divorce. These were all classified as adverse childhood events. These, just to clarify, these are the ones they did, but there's lots more adverse childhood events. So a child who has been separated from a parent because they were being a migrant, and as part of the migrant process, they lost contact with their parents. A child that had to go through migrancy and go uprooted from their own family. That's an adverse event. So there's lots more adverse events, but these are the ones they used for the purposes of the research. And what they did was they first of all found that in this Kaiser Permanente with the 17,000 people, they found 87% of people that can experience 2 or more adverse childhood events, 22% had experienced 3, and 12.5% had experienced 4 or more adverse childhood events. Now, they also found is that people from certain backgrounds were more likely to have experienced adverse childhood events. So those who marginalized populations, so people in deprivation, they'll have up to 78% have experienced adverse childhood events. Ethnic and racial minorities more likely, LGBTQ individuals more likely, individuals with disabilities and women and girls more likely to have experienced adverse childhood events as children. And for example, this is another one where Topsy found 39% had reported 5 or more adverse childhood events versus 8% by the original Kaiser Permanente study. So poverty, we as a society create poverty, and poverty creates trauma. And as we'll be going on to show how trauma is part of what happens, why people end up using drugs and in addiction, and why people end up experiencing homelessness. So because of that, that poverty, people often say to me, oh, anyone can end up using drugs. Yeah, anyone can end up using drugs. And lots of people who are wealthy use drugs. They use cocaine or hash, but they use powder cocaine. If you're born into, people who use crack cocaine and use heroin, they're almost definitely 99% come from areas of deprivation. And if they're using injecting drug behavior, they're almost 90% coming from drug addiction. I often say to my students, I go into medical students and I have a class of 150, and it says, many of you know someone who uses heroin or injects heroin. And you might find 5 or 6 people who do. And I say, many of you know someone who's died of a heroin overdose, and you might find 1. or two maybe. You go into an inner city national school and you ask the kids in that school and many of those same questions, you'll find almost 100% will know people who use drugs and 100% will know someone who's died of using drugs. So it is an issue of poverty, and poverty causes trauma and trauma causes addiction. I'll explain that in more detail later on. This is, for example, in terms of ages, the more, people who've experienced one adverse experience or two more adverse childhood events. And that's in poverty. As you can see, in poverty areas are much higher levels than in areas that are no poverty. And childhood trauma increases. Not only is poverty cause trauma, but trauma causes poverty. If you have a history of trauma, you're much more likely to end up in poverty or unemployment in later life. So it's bi-directional. So before we get on to the actual the statistics, this is was a great book called The Body Keeps the Score. And basically, the actual body does keep the score of trauma, because as I was saying earlier on, trauma affects the brain. This is two brains of 3-year-old children. On the right, left, you have a normal child, and on the right, you have a child who experienced severe neglect. We know that the brain is what we call neuroplastic. It changes according to stimulation. The less stimulation you have, the more stimulation you have, the brain actually grows and creates new synapses, neuronic synapses, and that leads to the brain growing bigger. And so this is the impact of severe neglect. We know that now the trauma actually affects the brain, and also I said it affects. We talked about the stress hormone, the cortisol axis. It also affects neurosynapses and causes different parts of the brain to develop in different ways and others to underdevelop. And we also know that now that it creates epigenetic connections. So epigenetic connections are where you actually modify genes due to your experiences. The environment impacts on how your genes are expressed. And this can mean that the impact of trauma in one generation can actually pass on to the next generation. This is, I was saying, the hypothalamus, pituitary, and adrenal glands access repeatedly to produce the fight or flight. That's the HPA axis. Adrenal cortisol production impacts on the body. Nucleus accumbens, that's the pleasure reward summits. That's affected by this whole issue. The prefrontal cortex, which is how we manage our behaviors, that's affected as well, and the amygdala. These are all the factors that are affected by trauma. This is the impacts of excess cortisol on the body, depression, hypertension, chronic fatigue, sleep deprivation, etc., etc. It has huge impact. So, and then there's the locked-in syndrome. The locked-in syndrome was prolonged exposure to being in this particular situation can result in people locked into a high state of alert. Now, just to clarify, we often think of this evolutionary. The whole idea of having an adrenaline surge when you perceive danger is that was an evolutionary adaptation to help us survive. So if you saw something dangerous, you'd have a surge of adrenaline to help you have more energy to fight or run, the fight or flight response. And it would cause your heart to go quicker so that you'd have more blood going to your muscles, your lungs to breathe quicker so that you'd get more oxygen into that blood that's going to your muscles, and your muscles also tense up. So, because they'd be ready to run. So all those are the symptoms of that there were an environmental response created. And what happens is if you've prolonged stress, you end up in high alert, because that is the best way to survive in a past time. In present time, it leads to actual people being in this prolonged highly responsive, ready to react type reaction. It increases tissue inflammation, the body's not able to repair itself, difficulty controlling impulses, and poor social interaction. So ultimately, while it may have helped us in the past when we were in danger in prehistoric times, nowadays it means it leads to shorter lifespans. And so I'll just go on to the next slide. This is institutional neglect of children. This is how it affects your stress hormones. So this is neglected, maltreated toddlers versus middle-class US toddlers. And as you can see, the stress hormone levels are much higher amongst children. The impact of trauma is huge. So let's go and look at that impact. So first of all, as people, I'm going to give you loads of slides with different statistics. Some of them counteract because they're from different studies, but they all support the same thing. adverse childhood events, you're less likely to be physically active, you're more likely to be a smoker, more likely to drink excess, more likely to use drugs, more likely to miss work, more likely to have severe obesity, diabetes, depression, more likely to attempt suicide and commit suicide, more likely to have STDs, heart disease, cancer, stroke, COPD, broken bones. Those who are exposed to childhood trauma, if you have 4 or more adverse childhood events, your life expectancy is 20 years shorter. That's the impact of childhood. It affects your lifespan. They're more likely to develop heart disease and lung disease. Compared to people with no adverse events, those with a scale of 4 or more, just to clarify, there seems to be a tipping point once you've had 4 or more adverse childhood events. So beyond when you've had 4 or more, things get much worse. You have 3 times the chance of COPD, 2.5 times the chance of STDs. You're twice as likely to smoke, 12 times more likely to attempt suicide, 7 times more likely to be an alcoholic, have alcohol problems, 10 times more likely to inject street drugs. I remember listening to Irving Welch. He wrote Train Spotting. It's a fantastic film about drug use, very funny. And when he was talking on the radio, and the interviewer was saying to him, Irving, you used to use heroin. He says, oh, yuck, yeah. He said, I used to inject heroin. And they said, and was that difficult to come off? And he said, no, it's not at all. And they said, but what do you mean by that? He said, and this is true, actually coming off heroin, it only takes 3 or 4 days of you go through cold turkey. But actually, it's a very safe thing to come off. You can just come off heroin. It's very uncomfortable, but you can do it and hang in there. Alcohol is actually dangerous. Coming off alcohol withdrawals are much more severe and dangerous. You can die from alcohol withdrawals. He said, I found it easy. I was just using heroin for fun. He says, the people who find it hard to come off heroin, they're the ones who are using it because they had a fucked up childhood. He said it on the news. The way we understand, when you come from a trauma-informed care, the way you understand people who inject drugs, these are people who have a trauma as a childhood. They've an inner rage. They're constantly feel low self-esteem. They're constantly, on high alert and ready to trigger into rage. And that is not a very comfortable feeling. So they are self-medication with medication to manage those feelings. That's the way we understand it. It's a form of self-medication to manage the huge rage, the low self-esteem, the shame that arise from the experiences of childhood trauma. Emotional problems. Childhood experiences underlie chronic depression. 2/3 of all suicide attempts, 64% of adult suicide attempts, and 80% of child adolescent suicide attempts are attributable to childhood adverse events. Compared with people with no adverse chance, people who have a history of trauma, 4 times more likely to, or 4 more adverse child events, 4 times more likely to be high-risk drinkers, 6 times more likely to have an unintended teenage pregnancy, 6 times more likely to smoke cigarettes or tobacco, 6 times more likely to have had sex under the age of 16, 11 times more likely to smoke cannabis, 14 times more likely to have been a victim of violence, 15 times more likely to have been a perpetrator of violence, 16 times more likely to have caused crack cocaine or heroin, and 20 times more likely to have been incarcerated at one time of their life. I told you before about, that the behavior we learn as the people who've had trauma learn is sort of to rage and anger. And I said to you, this is almost like an instinctive behavior and it's protective. I'll give you a story. I once was doing research on people experiencing homelessness, their behaviors, their health-seeking behaviors. And I met this man who was waiting for the mobile health unit. And I was just chatting to him. I said, what happened? And he said, I've got chest pain. And I said, what? And he described chest pain. It was classic heart chest pain. I said, you need to be in hospital. He says, I know. And I said, well, what are you doing here? He said, I've just been to hospital. He says, they kicked me out. And I said, what? So I said, get in the car and I'll bring you straight to the hospital. So I brought him straight to the hospital and I brought him up to the desk and there was a young, very nice woman there. And I said to her, listen, I'm really sorry, but this man needs to see a doctor. He's got chest pain. She says, no problem. Just sit, let him talk to me and I'll organize to take his details. So I said, that's great. So I sat down very chuffed with myself. And within a minute and a half, your man was shouting at him. And I went up and she said, he's shouting at me, he needs to leave. So I calmed him down. Then I said, I'm really sorry. I explained, he said, he's homeless and he's just very stressed. And I said, and to be honest, my name is Dr. Austin O'Carroll. And I said, and I'm fairly certain he's having a heart event. He needs to see a doctor. So we got him in. I was able to use my middle class assertiveness technique that I had learned from my parents to be able to get it through. And as part of that assertiveness technique, I was able to slip in the title of doctor, which is very effective when you want to assert yourself. He was using his assertiveness technique that he learned as a child to defend himself, which didn't work very well in a hospital. Now, imagine we were on the streets and both of us were out homeless one night. And we met someone who came up to us really aggressive and said, I'm going to hit you, I'm going to hit you. And he said, and he started getting aggressive back and says, I'm going to hit you, I'm going to hit you. He says, you hit me, I'm going to hit you back. That's probably quite protective. Whereas if I say, excuse me, my name is Dr. Austin O'Carroll, I'm likely going to get a bang of the head. So my surface technique would not work on the streets, unlike his. So that's why you need to understand the behavior and what it works for. Again, more it's showing how the use of the experience of adverse child defence leads to more likely to be imprisonment, heroin cracker case, violence perpetration, victimization, high risk drinking, early sex, etc., etc., etc. 60% to 7% of at least one adverse childhood events. It's the ones who have gotten up to 4 or more. That's when you get to severe and you're heading into the toxic stress levels. As I said to you, there's a tipping point when you go over 4 or more adverse childhood events. I'm going to skip this video because we haven't time. Because I want to go on to the talk about trauma-informed care. Trauma-informed care is about responding differently to when you see behaviors, and it's trying to understand those behaviors. So every day in my waiting room, as I said, I have people experiencing homelessness, and I have up to 120. There's people wandering around. A lot of them can't sit still, and I sort of understand that because they've learned to move around constantly as children. So you often find people who are homeless find it difficult to sit still. So there's a lot of banter and interaction going on in the waiting room. I love it. It's great fun, but people suddenly say, he's skipping me in the queue, and they go up and they're really angry. And we have to manage these behaviors every day. I mean, if you want to know the rage that they experience, when you think someone's skipping you in the queue, you know that rage you get? That's the rage they get, but they can't control it as well as we can. And that's because of their trauma of the background. So anyway, we manage these behaviors every day. So, for example, I have Tommy and John out there, and Cara and Jean, and every day they are chatting to people saying, come on, listen, you're getting angry, come on out and go for a walk. Or they're chatting and cracking a joke. Guy said to Tommy, I'm going to hit you. And Tommy he says, hold on. He takes out his teeth. He says, now you can hit me. And your man laughs. So we're constantly using things. I had a patient in here one day who was looking for a benzo detox, and was looking for benzos. And I was saying, oh, I'm really sorry. I've this way of saying no, because I discovered if you just say no, we don't do those, you're triggering a reaction. So I said, I'm really sorry, we're not allowed to do those by the medical council, but I can help you lots of other ways. I help you coughs, colds, and chest infections. And they always say, oh yeah, but I need benzos. And I say, oh, I understand. I use the broken record technique, which is, I really understand that, but we're not allowed by the medical council, but I can help you coughs, colds, and chest infections. And it normally works, but it wasn't working with this guy. And next thing, he he just says, fuck you. And he gets up, walks out in front of my crowded waiting room and says, that's one little fucking bollocks. And the whole room froze, and everybody went silent. So I opened the door and I said, excuse me, I am not little. Um, by the way, I am little because I have a disability, thalidomide. And he looked at me and he laughed. He says, you're mad. And he came back to me the following week, and the room dissipated and everyone laughed. So you need to use those techniques. Once you understand where the trauma is coming from, you use techniques to talk people down, to get people to go for walks, you crack jokes. You just work with them and you develop a relationship. And when they get to trust you and you say, Mark, you're losing it. I can see you're raising your voice. You're going to lose your place in the queue. They trust you, so they will listen to you. And we go out for a walk and they come back in again. So a trauma-informed care approach, though, is much more than just understanding trauma. It's much more than just understanding behaviors. It's about realizing the widespread impact of trauma and understanding a patient's paths for recovery. It's about integrating that knowledge of trauma into the way you behave with patients, into your policies, into your practices. So, for example, I had a patient here this morning, and he came into me. He is 6 years on heroin. He's sleeping on the streets. He has a severe abscess on his arm, and he came into me looking for heroin substitution treatment and treatment for his abscess. And I said, "Ooh, that looks nasty." And he says, "I know. I went to casualty last night." And he said, "I was in casualty, and I just started talking to another guy who's homeless, and they kicked me out." Now, I suspect it wasn't as simple as that. I suspect he was talking to someone in there, maybe loudly. I suspect someone said, security guard might have said to him, keep it down, and he might have reacted, and he probably got kicked out. That's not a trauma-informed way of approaching. But in this clinic, this only happened 40 minutes ago. In this clinic, every day we see experiences. Stigma is the biggest barrier for entry into hospital. I mean, just anyone who knows Clean and Cali, the Inclusion Health teams and James's and the Mater, they are transforming these things in hospitals, but it's still one of the biggest barriers. And that comes from I don't blame the security guards. They're doing their job, but they don't understand. They haven't been trained in trauma informed. So it's implementing in your policies and procedures and in reviewing all policies to see are they trauma informed, recognizing the signs of the symptom of trauma. And the big one is don't actively re-traumatize. Kicking a person out of casualty, you're actively traumatizing, and you kicked out the person who is most likely to be dead in the next year. There's no one else that I know who's more likely to be dead than this person I saw there in the next year. And we've just kicked him out of casualty. So, a trauma-informed care then, delivering trauma-informed care does not necessarily have to include trauma-specific service, trauma specialists, just an approach and a commitment not to review everything that you do from that perspective. Just to clarify, trauma-informed doesn't increase costs. It doesn't take more time. It improves physical health and well-being. It improves staff physical health. And this makes sense because when you do a trauma-informed healthcare, when someone gets annoyed with you, you don't look and think, you don't get angry back because you know this is coming from their place. They're not, it's, okay, sometimes it's because of what you've done and you have to take it, you have to accept that. But you don't take it as personally because you can see where it's coming from. And so you don't end up going home having felt rage during the day, and your stress hormones are nice and calm by the end of the day. It improves retention and treatment for patients. It decreases staff over by 84%, decreases sick time by 53%, and decreases worker compensation claims by 98%. It makes, it's such a no-brainer to adopt this approach for both patients and staff. And it's the idea of universal precautions. You just presume everybody has experienced trauma. Same way as we had this universal precautions for people with HIV. You just presume everybody. You don't presume. And once you make that and you approach everybody in the same way, everybody's experience will improve. Not just the people who've had trauma, but when you approach someone from a trauma-informed approach who hasn't experienced it, they'll still feel more engaged with. So it's a paradigm shift from what is wrong with you to what has happened to you. And I'm just conscious that I probably only have 10 minutes left in case you want to ask questions. I actually won't go through the extra slides.
You're okay, Austin. I think everyone's very captivated by your presentation. So no pressure from us.
Well, just very quickly, it's just a question now. I've got to finish off. It's that you're moving from, I can understand that trauma results in not being able to fully engage at the present. You're still caught in the past. It's more a can't than a won't. So when someone says they can't engage, you just stick with them. Often the time I'm trying to do is get them to come back to the next visit. So sometimes I'll give them bribes, I'll give them an Ensure, I'll give them some Valium just to get them to the next visit so that I can engage with them. The behaviors that are problematic for them are solutions to them. So for example, when I was doing my research, I met this guy, really nice guy, who was experiencing homelessness, and he always looked really aggressive. And I said to him, and he's a very gentle guy, I said, do you mind me asking, you're really gentle, why do you always look so aggressive? He said, that's just to protect myself on the streets. So it made obvious sense when he said it. And the actual behaviors such as smoking, alcohol, drug use, they're managing their trauma. That's their behaviors for managing the trauma. I can understand that no matter how lovely we are, we always present a threat, and we have to recognize that. By the definition, we're more powerful, so we represent a threat. Once anxiety isn't triggered for them, once you make a trigger, there's a cascade of emotions, and you have to work hard to regain it. Sometimes you can't, and you have to just hope they come back the next time. And see past these behaviors. Look beyond the smoking gun, and sometimes trauma is not the presence of a negative, the absence of a positive. Sometimes they just never had anyone. Anyway, so go back to the last thing. Behavior always has meaning, and understanding behavior is so important. There's a good bit more else, but I think I've given enough and I've stopped talking now. We'll take any questions. So thanks very much for listening to me, and I hope that was okay. Does someone, will I answer the questions, or is someone going to?
Hey, Austin, I'm here. I'm here in
the
wings. Well done. Thank you so much. That was a extremely interesting presentation. And we do have the chat open still if there are some questions. There was one question from Alice, she was wondering if you've done any specific research in that area around adverse childhood trauma in your own practice, and if you did, have you any recommendations or thoughts how to go about it? She's quite interested in the area herself.
What I say is we haven't actually specifically looked at trauma in our thing, but Sharon Lambert did fantastic research with Simon in Cork, which found, I forgot to include it, there was around 99% of people experiencing homelessness in Cork had experiences, had adverse childhood events, and very high levels of adverse childhood events. If you Google it, just Google Simon Cork adverse childhood events, you'll find the study. She's a fantastic resource. She probably killed me for suggesting that you contact her, but still, because I'm sure she gets lots of people, but she is brilliant, and I definitely would go towards her if you were doing that. Yeah, absolutely. I forgot to say, because a lot of this is also about open disclosure. And I just to say, you know, we make mistakes here at the clinic, and we always disclose. One thing I always found is that working in inner city Dublin and working with people who are, they're quite understanding, and we've always found, interestingly, that we're easily forgiven when we explain things. I do think, again, this. I'm not sure if this is really an area of open disclosure, but if you're asking me, one of the most significant issues in the health service is stigma. And stigma against people who use drugs in particular, also against people experiencing homes, but people who use drugs. They're the people who are most likely to die young in our society. And it's systemic stigma, like GPs, a lot of GPs won't take them on. GPs won't provide treatment for them, opiate treatment. And then in hospitals, as you said, we frequently see people getting barred. So, you know, that's not disclosure, but there is an element of reporting. But again, I don't want to report people because I think it's such a systemic issue, but I do think it's something we need to address.
Yeah, thanks, Austin. And certainly, I suppose, being a novice in the area, I feel so much more informed now after your presentation, but I did even before the presentation think, oh, how can this link in with open disclosure, in particular incidents and incident management? They can be very traumatic events. But I know you talked about that accumulative effect of being exposed to trauma. So I'm not sure if people or patients and families who are exposed to incidents, but we might have that kind of feel that they are traumatized or challenged in terms of dealing with it. I suppose that's a bit of a different consideration rather than the area that you're focusing on.
It is, yeah. I mean, obviously, national disclosure is a really important issue in our thing. I will tell you what I do think is important. What I learned about disclosure is that, you know, a lot of what we've been talking about is blame. You know, you blame people for drug addiction, you blame people for people experiencing homelessness. Once you start looking at blame, the concept of blame, I actually write about this as well. You start not blaming anyone. So in other words, you stop blaming the doctors who are stigmatizing, you try and understand their behavior and how you can address it. But it also allows you to look at yourself, and when you make a mistake, it allows you not to blame yourself. And by not blaming yourself allows you to be open because you're able to recognize people make mistakes. Now, if you make repeated mistakes, you need to look closely. But once you learn to stop self-blaming, and once you develop a lack of fear of blame, it makes it easier to disclose things. And I mean, I would be a fan of a non-blame approach to disclosure, which I know is not, you can't get a totally non-blame approach, but I know other jurisdictions that they have these, for example, I think in Australia and parts of America, and where they have non-blame open disclosure. So I do think you learn from working in this factor about the concept of blame, which actually helps you in disclosure, if that makes sense.
Yeah, no, certainly a lot of the points resonate, and I mean, you sound extremely compassionate. I know you've learned your skill and your craft, and you're just very effective in how you deal with your patients and manage them and support them. But you do come across as very compassionate, which is really encouraging. And I think
I just reply to that. I do think everyone who enters medicine, enters the health service, who works in the health service, are compassionate. And if they're not being compassionate, that again is a behavior that something's going on that prevents them. There's so many doctors who start off very compassionate and become hardened because of, and I think if you can learn, I mean, ways of learning to maintain compassion, I think trauma-informed care helps you maintain compassion. So, yeah.
No, that's That's really interesting. I think even the stigma piece that you mentioned around open disclosure, sometimes we make assumptions around whether people want to know or how they might respond to us being open and transparent. And maybe with this cohort of patients, there might be additional stigma that they might respond in a certain way if we are being open and transparent. We have quite a few questions coming in now. I think we've opened the floodgates a little bit. So just to do them all justice, from Patricia, how is your feeling on mindfulness for ourselves as a good way of helping with our responses rather than reactions?
Well, I run a GP training program that trains GPs to recognise deprivation with marginalised populations, such as experiencing homelessness. And as part of that, we have a self-care module. And as part of that, they do a mindfulness program. So I'm giving you a double-edged answer. I'm a big believer in mindfulness for those who it works for.
Yeah.
For example, I did a mindfulness course, and it's not for me. I did learn one very valuable thing. I learned that you can decide whether you want to think about something or not. So if I do cycling that's my stress management. I can decide to mull over something that's annoyed me at work, or I can decide to listen to the sounds and see the scenery that's around me. That's the one thing I learned, which is very valuable. So I think mindfulness can work for many people, doesn't work for other people. So definitely it's part of the armory.
Yeah, exactly. And having a few things, knowing yourself, what helps yourself. So Kieran asks, is trauma specifically linked to experiencing the adverse childhood event, or can it be linked to trauma experienced in adulthood?
Well, I mean, the one we're mainly looking at is trauma in childhood, probably because trauma in childhood, you're talking about someone who hasn't created their abilities to manage trauma. If you've developed skills if you've had a solid childhood, you tend to have developed a resilience to be able to manage trauma as an adult. So trauma, I suppose what I'm saying is trauma has an impact no matter whether you're an adult or a child. It's just in this work we're talking about, it's mainly looking at children because they are so vulnerable and the impact on later behaviors. Trauma as an adult, a lot of your behaviors are already preformed. I'm not saying significant trauma mightn't affect those behaviors, but for example, you're less likely to end up becoming violent if you weren't violent, if your trauma comes as an adult. It can happen, but it's less likely to happen. Impact on health, yes, stress hormones. If you experience stress hormones in the age of 20s, it will shorten your lifespan. It will affect your health, but again, not as significant as when you're in childhood.
Oh, that's really interesting. Lots of positive feedback coming in. Helen's comments, excellent presentation. You talked about epigenetics. Does this affect father to child or just mother to child?
Actually, I think it's both. It could go either way. So the trauma can affect genetics on both sides. That is controversial, that epigenetics. Everyone who promotes childhood trauma says, quotes a lot of research to show epigenetics. I have heard a person who's a purely geneticist say, oh, it's not that simple. So if you're interested, look up the research, but just be careful. There is two sides to it.
Okay, great. And from Adele Austin, do you provide TIC training for your admin and security staff, and how open are they to this?
Yeah, no, we provide training, trauma-informed training to them.
Yeah.
I'm also chair of the North Inner City Drugs Task Force. We've just rolled out trauma-informed training to, I think we rolled out 150 training places to services in North Inner City, and around 36 places on a University of Cork degree on trauma-informed approach. And we're going to roll out programs to the parents in the schools. So I'm going to be running, there's a particular film called Resilience, which you can buy. It's an American film. It's about trauma. And I'm going to run that and then run a session on trauma for parents and inhabitants of the North Inner City. And my idea behind this is I want to trauma inform the whole North Inner City, because I want them to understand that drug use is caused by trauma and not by badness. I want to change that narrative. So that's part of our policy as the North Inner City Drugs Task Force. So yeah, trauma-informed training, lots of people do it. I know of several organizations who provide trauma-informed training. And yeah, so if anybody wants to, I can get the names and we can send them out by email to you.
Well, that's really interesting. And I suppose my own experience, I worked in London for quite a while in one of the trusts that was in a deprived area in Camberwell in London. And certainly we always, I looked at the incident management side of things, and we had a lot of incidents around violence and aggression, but I didn't hear so much noise about trauma-informed care. It's probably on their radar in emergency departments and security teams. But, sometimes we look at these national quality improvement areas, and I just wonder, is there any correlation or targeted work that we... Anyway, I might link in with...
No, I definitely think we need to be trauma-informed training, particularly staff, like front staff, and I guess it's the security staff that need it most. I mean, security staff are really nice people, but often they're not trained. So, I said my security staff are really wonderful people. They're amazing. So it's just about how can you expect someone to manage violence in any other way that they've been taught? You have to retrain them. So, yeah, but I think it needs to go to it needs to go almost across the thing. I'd be a fan of doing it in schools, to be honest.
Yeah. Oh.
Sorry, Austin, could you repeat the name of the film? People are just asking in the chat.
Oh, it's called Resilience, I think, and it's Roco Films, ROCO Films. Sorry, it's a fly floating in front of me. Roco Films, ROCO.
There's just a particular question which is around alcohol consumption and pregnancy in Ireland. I don't know if there's any evidence around the brain development piece in the offspring, and maybe
there is unfortunately, yeah, severe alcohol. I mean, severe alcohol intake can affect brain development, and I mean, it speaks to the issue of, if you're asking me the saddest thing I've ever worked with, and I still work with, is when young mothers come in who are addicted to alcohol or drugs, and they really want, because these are people who had severe trauma as children, almost invariably.
Yeah.
And what happens is they think their lives are going to be transformed by a child, because this is their big chance to have meaning in their lives. And what happens then is they basically, when the child's born, often they find it hard to stay off the drugs. They take something, next thing the child is taken away from them. They absolutely experience huge, overwhelming grief. They're told you need to get your act together to stop using drugs or alcohol. But of course, with those feelings, what's the first thing they're going to do is go off and use drugs and alcohol. And you just see this incredible scenario where it all falls apart. I know the mother is going to end up back on drugs, hopefully doesn't die, and it's going to be a few months before we pull them back. And I know the child is going to end up in care for the rest of their lives. I think it's the biggest single tragedy I've experienced. As part of the North Inner City Drugs Task Force, we're doing research to find out, is there a better way of managing these situations? Should we be investing the money into providing high quality care at that moment? Because the costs of both what happens to the mother and child in later life are huge. Like, that's so traumatic as a start of life. It's awful.
It's tragic. Yeah, it's a bit emotional, but it's really interesting to hear your experiences around that. The questions are still coming in, Austin. I hope that's okay.
No problems. Go ahead. Yeah.
If we need to finish it up and there are any outstanding, we will follow up with our audience as well and get the answers for you. Is it possible not to remember your childhood trauma, but later life behaviors indicate that you had some kind of childhood trauma?
Yeah, I mean, there's a lot of times what often happens when they react to the trauma, they're not relating that reaction to a particular event. I think people who've had traumatic backgrounds tend to remember it. We all have blanks in our memory, and you blank out certain things. And so I think everyone, like I know I spent a lot of time in childhood in hospital. I don't exactly remember all the details of it, but I still remember it. So this idea of suppressed memories, there was a thing in the past about suppressed memories, which it became controversial eventually. So I think generally when people have experienced trauma, they will remember that, but they mightn't remember all the details, because we often do manage to suppress memories. When they react to something, they are not linking that to past experience. They're in the moment. Even though it's been determined by past experience, in the moment they're reacting. They see it all about you, not about what happened to them as childhood. So that makes sense.
Yeah, that's clear. Another question, what are the main setbacks that you have experienced in your practice in dealing with trauma patients, and how do you move forward with them as a practitioner? I know you've given an example there about the mother.
I think the thing I have to do is I mean, obviously you've got medical skills. I can give treatment, like getting people onto methadone. Methadone has a bad name because people stay on it for so long, and I have issues about people staying on methadone long. But when you have someone coming in, like this morning, who has a massive abscess on their arm, who is injecting into their groin, who could die of an overdose tomorrow, who's living on the streets, and I start them on methadone, and I know that in 3 months they'll be in their own accommodation. They won't have these medical problems. So you have medical things. But the things also you have is yourself. I mean, I'm a big believer that it's about engagement. First of all, you have to try and engage them and gain their trust. And the second thing you have to give people is give them hope. I think hope is a huge thing we give as medical practitioners. And when I say as medical practitioners, a cleaner talking to a patient can give them hope. It's not just, it's anyone who deals in the caring services. Often we give hope to people. And that's what we do. I had a patient yesterday who, when she first came to me, was just giving up on her accommodation and leaving her job because the financials were making it impossible for her to earn enough money to pay the rent. And she came in and she's applying for a university course yesterday. And all I could treat her wasn't with drugs and with that. It was just saying, come on, you're smart. You can do something with this. Don't give up the accommodation. Let's work on saving it. And let's work on the job. And over time, give us enough time to get you a better job. And did you think about going to college? Because you're smart. So sometimes it's just being able to give them things. I had another guy this morning who has been attending me for 8, 9 years, and he's just been accepted by Trinity Access program. So, and not all of them are going to end up going to university. A lot of people just hope means about getting in touch with their families, pulling their lives together, getting to see their kids. And it might be getting reunited with their kids, or it might be being able to visit their kids once a week. But you need to find out what hope has meaning for them and then help them work towards that.
Yeah.
So
it's interesting for me. I always feel my sense is that GPs are under so much pressure and time and seeing that, but that you can manage that and instill that within a short time frame is really empowering.
Well, see, I trained as a counsellor, and one thing I learned when I came back to GPs, you can't be a counsellor. So I have a counsellor in the practice, and we use them all the time.
Oh, great.
But actually, it doesn't take long to say, Jesus, you're fantastic. Have you ever thought about doing something with that? Actually, it doesn't take long. I can run that in a 10-minute consultation. And you'd be amazed what you can achieve in 10 minutes. And sometimes it's an offshoot, because the other thing is, don't forget, we see them regularly. And by seeing them regularly, you develop the relationship. So often it's a few comments, then you build on that. So it can happen. It's not as difficult as you think.
Yeah, but I think that's something I'll take away from the talk. Now I don't have that much clinical exposure anymore, but I think anybody on this webinar today can take that lesson away and just a positive reinforcement of when you meet somebody who maybe seems challenging but has underlying trauma that's kind of informing behavior and that. So
I think as a medical practitioner, you have power, because the fact that you believe in someone is actually, they think, Jesus, this is someone, they see you up there. Doesn't matter whether you're physio or OT, they see you up there. So if you have a belief in them, that actually has a power. And I also refuse to be called doctor. I find if you say to them, call me Austin, it actually gives them a sense of feeling of respect. So so I think you actually have power by being just a practitioner.
Yeah. That's the first thing you said to us when we met earlier. So is there any research about healthcare practitioners and their own trauma or childhood?
Sorry, I missed the question there. Was there any research about?
Is there any research about healthcare practitioners and adverse childhood events or trauma? And how?
I actually don't know on that one. No, I don't know on that. I do know trauma-informed prevention helps healthcare practitioners have less stress, but I don't know about trauma is endemic, so there were definitely healthcare practitioners who have experienced the trauma. I don't have any research specifically into that, though.
Okay. What do we know about people who have experienced 4+ ACEs and who do not show typical signs of trauma in adulthood? Are they likely to behave in other unusual ways, such as being overly helpful and caring, concerned for others?
I don't know if that, but I think there is a strong point there. Is the presumption that everyone who's had more and more adverse childhood events is going to turn out with significant problems? No. Many people do learn to manage and recover and develop a resilience. It's just you're more likely to develop those behaviors. I don't know if you don't develop those behaviors, you exhibit in other ways. I can't comment on that one. I don't know.
Okay, and I think the final question, that's also an interesting, colourful question for you, Austin, to challenge you at the end now. This person attending the webinar today said that she recently heard that psychedelic drugs or therapy helped someone to access their childhood memories, and they discovered why they are clingy in relationships. What is your thought on this approach?
Just to clarify, I'm not an expert in psychedelic therapy. I know of it. I don't have anything negative to say about it, but I haven't done any research into it, so I'm not going to say yes or nay. I'm neutral on it because I don't know enough.
That's
yeah.
perfect. Austin, listen, thank you so much for that really enriching presentation and for making time for us. I know you have a busy clinic today or practice session today, so I think there's a lot of positive feedback coming through the chat, and I think a lot of us will take away something from today, and it'd be nice to link in with you again in the future, if that's okay.
Be delighted to. Thank you very much.
All right, Austin, enjoy the rest of the day.
Okay, see you then. Take care. Bye.
Bye. And for everyone's,
thanks
we'll
for all
send
the
on
translation.
those.
Sorry, thanks for the translation as well. Thank you.
Thank you. That's all right. And any information we get from Austin, we send on to everyone who's attended the webinar, and we will share the slides as well. Austin confirmed that. We just have a couple of closing slides from our side as well. You will receive the usual email with a short survey on today's webinar. And as ever, we're grateful for your feedback and evaluation. And in particular, if there are any other topics that you think might be relevant that you would like to hear more about, we do have our next webinar lined up for the 19th of November. There's some colleagues from New Zealand who are going to share their experience around engaging with patients and families as part of the incident management process. So some of the terminology we use is around meaningful involvement. They're very strongly influenced by their Maori culture, which has really shaped their approach to incident management, which will be quite interesting. So we hope to see you then. Just some of our additional information. So there's some QI work underway. If anybody wants to contribute to that, it's on co-designing an outcomes-focused monitoring system to support continuous quality improvement in disability day services. We have the QR code there, which we will also share as part of the slides going out. As ever, you wouldn't be on an open disclosure webinar if we didn't mention our mandatory open disclosure module. You know, it's an introductory piece. It's a very short module. All our staff are required just to have that introductory piece so they know what we mean when we talk about open disclosure, and we'd encourage you to take us up on that. It's on HSE land and has the relevant CPD points associated with it. And then we have the Module 2 e-learning program as well, and that is for our staff who might engage in the actual open disclosure conversation. So generally our clinicians, managers, senior nurses, or senior colleagues. And at this point, I will close. Thank you, everybody, for making time to listen in today. I thought it was a brilliant webinar, and we're very grateful to Austin for presenting on this topic to us. We're very grateful to Aisling and Clodagh for doing sign language for us, the interpretation for us today. As ever from me, I'm very grateful to Loretta, Kelly, Ellie and Emma in the organisation and facilitation and support for the webinar. We hope to see you again in November. Thank you, everyone. Take care.
Your phone was one of our phones is not running there, so I think it must be yours right now.
Sorry, you might end that. I'm just out of practice session here to save the recording if you just want to come out there.
Okay, sorry.
Thanks.